I want to go back to some of the patients that Chris described, some of the older, frailer patients, the really young, healthy patient, but the patient with that rapid PSA doubling time in the, in the traditionally imaged occult non-metastatic setting. And again, I agree, that's a bit of a misnomer. We're going to consider this really low metastatic disease burden. But Chuck, there's been 3 studies now, big randomized studies that have demonstrated some clinical benefit to early androgen receptor targeted therapies. Do you want to summarize some of that data for us and give us sort of your take on how you think about this field now and maybe how it's evolving?
Sure. So as everybody knows, we now have essentially 4 novel hormonal targets for CRPC available: abiraterone, enzalutamide, apalutamide, and darolutamide. 3 of these drugs were tested in randomized placebo-controlled trials in the non-metastatic setting. Abiraterone was tested in this setting, but not with a placebo control. So essentially what was demonstrated is that when, and I'm just going to speak in aggregate about the space, placebo treatment in the setting of a relatively high-risk non-metastatic setting leads to the development of metastasis in a period of around 18 months, 17 months, somewhere in there. Treatment with darolutamide, apalutamide, enzalutamide all prolong those profoundly, and in the range of about 40 months for darolutamide, for example, which is the most recent approval. And so there's no question that these drugs are active in that space. And what's emerging now is the data on, well, what does that mean in the long run in terms of when do patients, if they do develop bony-related pain, when did they develop a decline in quality of life, and those types of things. And so there are some data that are emerging that are worth talking about. Let me focus on ARAMIS, which was the most recent study in this space, the most recent approval. And to get to Chris's point, these patients, and I believe this is relatively true for all of these studies, had a short PSA doubling time. So the median for the ARAMIS study was 4.4 months. So these are patients who are going to develop metastases. These are patients, many of whom are likely to die of prostate cancer, ultimately.
Or they have occult metastases already.
Or they have occult metastases.
We just don't see them yet,
which I would say that they do have occult metastases, yeah. It's not non-metastatic. It's not visually metastatic CRPC. Metastasis-free survival with darolutamide, 40 months compared to 18 months with placebo. PSA progression-free survival, so the time until the PSA rises, relatively quick, 7 months in the placebo arm, 33 months in the darolutamide arm. So what that's telling us is patients are getting 2+ years of disease control out of these agents. And the data were updated as by Dr. Fazazi at ASCO in 2019, demonstrating that reductions in quality of life were delayed with therapy. In other words, I think the question is, if the disease at this point isn't hurting the patient, we want to make sure that the treatment is not hurting the patient. And I think that's a key point. All of these drugs have side effects. All of them are hormonal therapies that can induce some fatigue and hypertension and rash in the case of apalutamide. And so these come at a cost. But the QOL data, for example, demonstrated that with placebo, quality of life, the median time to quality of life deterioration is 14 months. So that's pretty consistent with the metastasis-free survival. The time to pain, or the pain-free survival, was about 40 months, for example, in the darolutamide-treated patients. So they go a long time before they begin to have symptoms of the disease. All of those are important clinical variables. The time to quality of life deterioration in the darolutamide-treated patients was about 23 months. So when you put that together aggregately, it says there's a pretty good case to be made for treating versus not treating non-metastatic CRPC. I think there are a lot of open questions about when exactly to start that treatment and how to integrate the novel imaging and which of the really 4 drugs to choose. That's something that we as a field have to wrestle with for a while.